Hi, I am Debbie Sukin, Regional Senior Vice President, Houston Methodist. I am honored to moderate the Future of Stroke Systems of Care panel. I would like to first introduce Stacey Moye, nurse practitioner. Stacey Moye is a vascular neurology nurse practitioner. She obtained her Bachelor of Science in Nursing from the University of Texas at Austin and a Master's in Science in Nursing from the University of Texas Science Center in Houston. Her nursing career began at Houston Methodist Hospital Emergency Department, where in this role, she served as stroke champion, focusing on improvement stroke metrics and relationship with EMS providers. Houston Methodist was the first hospital to obtain DNV Comprehensive Stroke Accreditation. Stacey was promoted to be one of the first stroke nurse practitioners for Houston Methodist Hospital, where she provided acute management of stroke patients and participated in multiple stroke trials. In 2017, Stacey transitioned to Houston Methodist The Woodlands Hospital and implemented the teleneurology program, established acute management protocols for the emergency department, radiology department, and guided stroke care through the hospital. Stacey was instrumental in assisting Houston Methodist The Woodlands Hospital in obtaining DNV primary stroke certification within the first year of opening, and DNV Comprehensive Stroke Accreditation at approximately 2.5 years. Stacey.
Thank you, Debbie, for the introduction. I am so excited to be here today, and I am so excited to share how we integrated EMS into our emergency department. Here are the objectives: EMS technology and communication, collaboration and strategies with EMS, and sharing of patient data and outcomes. Let's get started. First things first, we need to understand who regulates EMS. The Texas Department of State of Health Services regulates EMS and trauma systems. In the state of Texas, we've divided into 22 regional advisory committees. These advisory committees develop, implement, and monitor the regional systems of care. Our RAC, which includes the city of Houston, is over about 5,783,000 people. It's important to understand that we have a heavy focus in our regional advisory committee on stroke, chest pain, perinatal care, and maternal care, as I said. Our RAC has a stroke committee which collects and facilitates and coordinates the care of our stroke patients. How have we done this? We have started to give them our data in regards to stroke metrics. It's important to understand that each month our stroke coordinators are giving the numbers of stroke patients that we take care of, how many TIA patients, how many subarachnoid patients, and intracranial hemorrhage patients. Of our stroke patients, they ask us who received TPA, who didn't receive TPA, and if there was a delay and why. This data is then collected and shared amongst all of our regional CEOs, so we know what is going on with other hospitals in our system. In 2020, we as a region have decided to collect the data on our care for our large vessel occlusion patients. This data is currently blinded, so it's only shared with your senior leadership. But if the past tells the future, it's going to start being shared amongst everybody. The first, this is Stimo. He is our first a mobile stroke unit that was introduced in Germany in 2008. I would just want to say congratulations to the UT Health program for introducing the mobile stroke units in the United States and in Texas in 2014. These mobile stroke units are equipped with CAT scan machines. They allow providers to obtain diagnostic imaging in the field, which then translates to patients possibly getting life-saving intervention at an earlier time. They also help us to guide the care of the patient to a comprehensive stroke center or to a primary stroke center. Studies are ongoing currently with mobile stroke units. Obtaining vascular studies like CTAs, this would help us to ensure that the patient's going to the correct site. These are not my slides. Not every city is lucky enough to have a mobile stroke unit. So what do we have? We have pre-hospital scoring scales like the Cincinnati, the Lambs, the RACE. I would just like to talk a little bit about these pre-hospital assessment scales. They have a high predictability in determining if a patient is having a stroke. It's important to know in your region which scales are being used. If you know what scales are being used in the region, then you can properly educate your staff, as far as the emergency physician, the nurses, and the techs, about the patients that are likely coming into the hospital.
I want to apologize to the audience for our technical difficulties. So, Stacey, let's just pick on back up. You shared about these incredible, obviously, with the ambulances and the introduction of what that has meant in terms of really stroke advancements. And one of the things I want you to talk about is really how that has changed and really built upon our relationships with EMS and how you really have spearheaded that.
Okay, so I want to do a little bit about going back and talking a little bit about our story. I think it's important to understand where we've come from and where we are today. In 2017, we opened our doors to the community. It was July 1st, 2017. And in 2017, we only had 39 patients that carried out with them the diagnosis of stroke. And, that year was trying. We were a new hospital. We were seeking our primary stroke accreditation. And I just want to go back and reflect, because at that time we already had comprehensive centers in our market. We could see one through right out the window from our front door. And so that facility is 0.7 miles away. So we really had to focus on how we were going to get EMS to bring patients to us, how we were going to build a relationship, how we were going to have people trust us. And these are some of the things that we did. We did a day in the life. What's day in the life? Looking back, it was the most phenomenal thing that we had done. This is where we basically acted as if we had patients. Each person, each nurse, each physician, each technician was given a script, given a role, and we acted out what it would look like to come to our hospital. It was so amazing. We learned key things. We saw what worked and what didn't work and what needed to be reworked. Some examples of those were we have an awesome CAT scan machine. It has a powerful contrast injector. However, it didn't work with certain tubings that our EMS providers were putting in the IVs on patients. So we also learned that we couldn't have an EMS stretcher, an ED stretcher, and a teleneurology cart in CAT scan at the same time. So by doing a day in the life, we were able to work through what was going to work and what wasn't going to work. And that happened really before the hospital even opened. We did ride-alongs with our EMS providers. And usually in 4-hour blocks, every neurology provider, every neurosurgery provider, and every neurointerventionalist went out on those trucks. You saw the paramedics, you saw their stations, you saw their protocols, you saw how they interacted with patients, and this was huge. It was an eye-opening experience, and it's really where I felt like the relationships were built with the paramedics in our community. We did multiple different educational events. We participate in their educational events as well as them participating in ours. We have routinely scheduled EMS meetings. So they're welcome to our interdisciplinary stroke committee meeting every month, and we go to their meetings. There's a trauma neuro meeting that we go to. So it's really about a relationship and collaborating. So if you're thinking about how to better the relationship, I strongly encourage just going out there and saying, "Hi, I'm Stacey Moye, I'm the neurology nurse practitioner," and interacting. We have our medical provider, our paramedics come with us to every time we go to the CAT scan machine. We have them go with us into the labs. It's a transparent process that we have welcomed them in. And so really and truthfully, I feel like the collaboration of obtaining primary in such, less than a year and a comprehensive designation at 2.5 years wouldn't have happened if we didn't collaborate with EMS. So year one, we had 39 patients. Year two, 139. And that third year, 2019, we took care of 500 stroke patients. So I really think that this EMS collaboration is huge. And I just want to say thank you to any EMS provider that's actually in the audience today. The other thing we did that I didn't mention was sending quick feedback. I think it's important to understand that once we gained the trust of the paramedics and the community and the patients were coming in, that we send quick feedback. That, after we would do these large mechanical thrombectomies, pulling out that clot or opening up a vessel, we told the paramedics, we shared the outcomes. And the other thing we did was we had reunites, where this is where we would bring the patient and their family, EMS, and our emergency care providers into one room and all get to love on and congratulate and share the stories of our patients. I think the process of EMS integration into the emergency department is founded on the utilization of best practices and evidence-based medicine. The collaboration seems to be the most successful when there is open communication and data sharing. Thank you, Debbie.
Stacey, thank you. So I just really want to talk a little bit more about, so given the technology, I really want you to focus on with the audience about how this has really changed, if any, the approach to stroke care. As you have now been in the field,
Yes.
You've been on the front lines. Talk just a little bit about that. Aside from the collaboration, that's really how you're building the programs. Talk about how actually the care has changed.
I think that the care has changed because it's a much faster pace. Technology has allowed us to work with outside of our four walls as a hospital. We are really starting care in the field and on scene. And with the technology that we have, that we mentioned about the pre-hospital stroke assessment scales, those paramedics are giving them to us, and then we are acting in the hospital to be 100% prepared on their arrival.
Excellent. And I'm also just wondering, when you talk about establishing the significance of the collaboration with EMS, did you do it alone?
No.
How did you do it? Did you pick up the phone and call your local EMS provider? How did you really initiate that with the team?
We're lucky enough at Houston Methodist to have a team of people behind the scenes, our business development, as well as our EMS relations. EMS relations was able, to set up the meetings, and we would have just face-to-face conversations, a round table and a cup of coffee, stating this is our goal, this is our plan, this is our vision, and here's how we plan to accomplish it. And then once that relationship was formed, I would say, it was really just saying, this is how Houston Methodist is going to do things, and we want you to be on our team. So here's your invitation. Come anytime.
Excellent.
So Stacey, I've been able to be a part of the Woodlands growth process from its inception, and it's nothing short of remarkable how much growth you guys have had. Being a physician, I can honestly say there are challenges in trying to get the correct clinical information from providers with the last seen normal, what medicines the patient is on. Can you just talk about that process of how you were able to engage EMS and sort of fine tune those details that as practitioners we need to know to figure out what's the best treatment course? It's certainly a challenge that I encounter at my hospital, reinforcing what is a last seen normal, when did symptoms start, and all the other pertinent clinical details.
Absolutely. So with going back to the day in the life, we really worked it out in our scripting then. We reinforced it with our ride-alongs. And then every time that we invite them back into the imaging department, they see the same routine that I have and that the other providers have. You know, now it's a very known thing. When I go to Methodist, that nurse practitioner is going to ask me for the phone number. So they hand me the phone number. We've also instituted a business card that can be given out to patients' family members while the paramedics are packaging and loading up patients. And they can call ahead and talk to me, actually. And they will, you know, I can start asking questions. So those are just some things. It's the routine, I think, of saying, this is what I need every single time that you come in. And it's been really well received.
That's great. So just as a concluding question, Stacey, so do you think it's changed patient outcomes, the changes in the advancements here?
Absolutely, 100%. I think patient outcomes are affected. I think that our patients are doing better, truthfully. We're getting to them faster, we're treating them faster, we're intervening faster. We have numbers and data to prove that, but really and truthfully, it's about the patients that, you know, get back to doing what they were doing before that they came in.
Excellent. Thank you.
You're welcome.